great pleasure to introduce Jiří Vejmelka, who is a clinical practitioner. He works at the Department of Internal Medicine of the Thomayer Hospital and Third Faculty of Medicine of the Charles University Prague, and he's gonna give us a talk on the sort of microbiome and therapeutical approaches. So the floor is yours.
So thank you very much. Good evening from Prague. I really apologize for some technical issue with my microphone, but thanks to the smart device I'm in, so this is very perfect. Very cordial greetings from the epicenter of COVID infection from Prague. I'm working at Thomayer Hospital, and I had a lecture for medical students a few moments ago. And as you can see here, there is the panorama of Prague Castle. And when I describe myocardial infarction finding in ECG to the students, I always say, just to remember, there is some mnemotechnic, and this looks like a Prague Castle. So I really have to say that we are very big stressed at the moment. There is much stress. And for example, in the morning, I got to know that some of my personnel got COVID. So this is really very difficult. Try not to get a myocardial infarction, as you can see here in ECG, and as well as in the panorama of Prague. Of course, that you are invited to our capital in some better times. And you can see that our emergency cars in Prague, they also have the shape of the ECG and of the myocardial infarction. So special thanks to Martin Zach and to all the organizing team for very big enthusiasm and for the work they have done. It's really a downright pleasure for me to take part in that very interesting conference. I'm a clinician, and I have just started also to be very interested in the research. So thank you very much to all of you, to your excellent talks, very interesting lectures, and special thanks to all of you who are just fighting the COVID, helping us in the hospitals, and crossing your fingers and trying to discover anything that would help us to defeat the virus. So this would be very simple, like this smartphone, to see who is infected and who is not infected. That would really help us, but we don't have such app at the moment. So my lecture is divided into three parts. First of all, I will just introduce my hospital and the microbiome. I'm really very sorry for the movements I do. My microbiota is really very emotional, as you will see, so sorry for that. Then in this middle part, I will just talk about our Czech project that is called FMT-CZ. It means fecal microbiota transplantation in the Czech Republic. And in the Finnish part, I will talk about our project that is focused on FMT in IBS patients. So, as Martin already mentioned, I work at Thomayer Hospital in Prague. It's quite a big hospital, one of the biggest hospitals in Prague and in the Czech Republic. I work at the Department of Internal Medicine, including gastroenterology and endoscopy unit, and we are very focused on microbiota. This attracts us, the microbiota. It's a phenomenon. We are really very eager to know everything about our microbiota. And I always say to my colleagues and friends, if you speak to anyone who is interested in that field, this is for hours and hours talking about our microbes that help us anytime. So we have mouflons in the area of our hospital. So here you can see the macroscopic gut microbiota of our mouflons. So we have to be very careful when coming into the hospital. And this is the headquarters of our hospital. And here you can already see the microbiota from a healthy person. It's a stool that we used first in 2013 to the patient suffering from very severe gut microbiota alteration from recurrent Clostridium difficile infection. And we are really shocked and surprised because of the very quick effect of this method. We used it in that patient suffering from the diarrhea for weeks and weeks. And very shortly after the procedure, we were very successful and there was no diarrhea any longer. So we started to do the method and we are attracted by the microbiota, particularly the gut microbiota. As you can see in the picture, my sister, she loves painting and drawing, so she just depicted the gut. So it's really very many bacteria and many microbes in our gut. And we want to know what is the code of the world, what is the code, what is the cipher. And this is very difficult because at the moment, we don't know what does it mean a healthy microbiota, because the microbiota is really unique in all of us. And we try to guess what is the number of the microbiota, how many microbial cells do we have on and in our bodies. And you can see that we don't know yet, but it's almost 1 to 1 or 1.3 to 1 for our microbes. There have been several projects that want to do the genome, or better to say the microbiome analyses. So you can see one of the most important projects, Human Microbiome Project, European MetaHit, American Gut. And thanks to Open Biome, this is very good project that concerns stool banking. We'll talk about it a bit later. So when talking to the patients, I always say you have something really precious and it's your microbiota. So we have to take care of the microbiota. And we want to try our best in our research. And I sometimes try to guess, can we just be successful to solve the problem, the cipher, or is it unsolvable? Is it so complicated, the microbiota, the interactions, microbe, host, microbe, that it can be compared into some unsolvable puzzles, as you can see here on the screen, 14 to 15 or 5 rooms puzzle that probably can't be solved. So the question is, what has changed? The world has changed, as Tolkien says, as is in the Lord of the Rings. But what has changed, if we know from the history, that Hippocrates said all the disease begin in the gut. So we know it, or I think he really was right. So can we say that all the disease just begin in the microbiota alteration? So this is a very difficult question. So concerning my field of interest, it means functional GI tract disorders. We have to talk about irritable bowel syndrome. Irritable bowel syndrome, it's a typical syndrome concerning the functional disorders. There are 3 main subtypes. IBSD, it means diarrhea predominant, or IBS-C, like a constipation, or a mixed type, or a subtype that is post-infectious irritable bowel syndrome. It means that you get some GI tract infection and afterwards you develop long-term condition, long-term disorders that can already be classified like irritable bowel syndrome, as you can see according to the Rome 4 criteria. So gut microbiota changes. We want to just map the microbiota changes in the disease and of course in health. We want to know which changes are in there, the changes just including the content and also the function of our microbiota. So as you can see here in the picture, there are some shifts within the gut microbiota in patients suffering from irritable bowel syndrome. But as our microbiota is individual, it's very difficult to generalize that and to help patients. So as for the second part of my lecture, I just want to introduce our Czech project, fecal microbiota transplantation in the Czech Republic. I have forgotten to mention that fecal microbiota transplantation is a very old technique that was already used in ancient China, and it's also comprised in Indian Ayurveda. And it was used to heal diarrhea, so it's not a completely novel thing for us. And as we started to use this method in our department, we have just said, okay, it is the time to organize the network within the facilities that provide also this method in the Czech Republic. So we have started this unique pilot project that was launched in 2016. And this project actually wants to improve the cooperation among the centers in the Czech Republic. And we try to get the data from the centers concerning the FNT procedures. And we afterwards present the data on a symposium that is called Clostridium difficile Day. It's a day where we are focused on Clostridioides difficile infection in general, but also on some gut microbiota alterations. So you can already see the results of this pilot project. So in the Czech Republic, we have done over 600 FNTs and since 2010. And the success rate was very high. You can see 80% of the procedure. It is really something surprising to restore the gut microbiota and to help the patient and to heal the Clostridium difficile infection, just to prevent the next gut microbiota alterations. So as you can see in the graph, it is almost 50-50, either the departments of internal medicine and gastroenterology or the departments of infectious diseases. In the middle graph, you can see the major indications of this procedure. This procedure is sometimes also described human probiotic infusion. So human probiotic infusion, it means a stool from a healthy donor that is administered to the GI tract of the patient. So the major indication in the Czech Republic, it is a recurrent Clostridioides difficile infection. And on the right graph, you can see that the route of administration of FNT was mainly the upper GI tract. So these are some results. We are looking forward to the next cooperation within the centers. Unfortunately, we couldn't run this year Clostridium difficile Day due to COVID. So we hope the situation is going to be better in the course of the next year. And I'm just getting to the third part of my lecture. So we want to broaden the indication spectrum of this method. Around the world, the recurrent Clostridium difficile infection is the major indication of this procedure. But we know that in many diseases, the gut microbiota is altered, and fecal microbiota transplantation or fecal microbiota therapy, that's the term I like because it's a therapy by the microbes, can be also used in some other indications. So it seems to be very perspective to use this method in patients suffering from ulcerative colitis and in patients suffering from some other gut microbiota alterations, including also patients suffering from IBS, irritable bowel syndrome. And concerning my patients suffering from irritable bowel syndrome, they are really very properly examined. So all the endoscopies, celiac disease is excluded, some endocrinology problems are excluded. And I can see that their gut microbiota or body microbiota in general is suffering. And there is a very big spectrum of some other problems the patients have. The most of the problems are digestive problems, and we want to influence and to improve the gut microbiota function. We have many tools. We have diets, some special diets, some restrictive diets. We can just advise the patient to just increase the fiber intake. And we also have probiotics, symbiotics, it means probiotics plus the prebiotics. But we have very powerful tool, it means the fecal microbiota transplantation. That is really very successful treatment, as we have seen in a patient suffering from Clostridium difficile infection. So this is our team. Our team, one part from Thomayer Hospital, one part is from Motol Hospital, that is actually one of the biggest hospitals in Central Europe. So we are very happy that we can cooperate to hospitals. And this work is supported by our Czech Ministry of Health. We have visited Norway, Harstad. It's very nice town, and I can see behind Martin that there is still the Aurora Borealis, a very nice scene that we just really wanted to see when we visited Norway, but we only see very small and short part of that. So, but we, of course, were not disappointed because we had the occasion to visit the only stool bank in Norway. It's in Harstad, and in the hospital in Harstad. And so we are very happy that we got to know their team, Peter Johansson, that actually realized the first randomized clinical trial concerning the fecal microbiota transplantation in a patient suffering from moderate to severe irritable bowel syndrome, and they were very successful. So we were really inspired by them. And our goal now is also, or what we wish is to just run a stool bank also in the Czech Republic. That would be very helpful for our patients suffering not only from some severe gut microbiota alterations like Clostridium difficile infection, but some other diseases for the future, like irritable bowel syndrome, ulcerative colitis, and probably some other constipation, for example, in Parkinson, the Parkinson disease patients. So this is already our clinical trial. So FMT and IBS, it's a randomized, double-blind, crossover study utilizing a mixed microbiota. This mixed microbiota will be derived from healthy individuals. So our tasks are particularly the selection of healthy donors. So special thanks to Jakub Hurich from Motol Hospital, from a microbiology department. They do a great work, and we try to help them as much as we can to get healthy donors. That actually is very complicated at the moment because the donor has to be healthy, having a very healthy living style. And at the moment, you can see that everything is complicated. The world has changed. Also because of the coronavirus, there are many obstacles, but you know, it's said the Latin proverb per aspera ad astra. So we have managed to choose the donors, but at the moment we get to, okay, COVID positive, okay, COVID positive, so we have to wait. And this is really very complicated for all of us, even concerning the clinical trials that are based on microbiota donors. So, of course, the main goal is the creation of study substance, recruitment of patients, then the clinical trial itself, and of course the follow-up. We want to see what will be the effect of fecal microbiota transplantation on the microbiome, of course the effects on well-being, anthropometric parameters. So the substance will be the same, identical across the whole trial. The FMT will be administered via enema. There will be 3 arms, and thanks to Motol, thanks to Jakub and his team, they will do the microbiome analyses. We will do the dietary records analyses, IBS scores. And here in this picture, you can see the design of the trial. Actually, the active substance, this will represent 1/3 of the prepared vials, and those 2/3 will be placebo. It's actually the placebo because this will be autoclaved. So there will be the death microbes. There will be 4 enemas per trial, per patient. So either 2 active and 2 placebo enemas, or 2 placebo first, 2 active afterwards, and or the 3rd arm will be 4 placebos in the course of the whole clinical trial. So we, of course, will have much to do. Here you can see the chart. So, of course, that there will be the bioimpedance and detailed anthropometry, some serum workup, psychological evaluation, dietary questionnaire. As I have already mentioned, the diets represent very powerful tool that can shape our gut microbiota. So this all will have to be taken in account. So, from my point of view, I'm really very happy that we got 7 donors that are healthy, that are motivated, they are volunteers. So you can see it's very altruistic. They want to help our patients. And one of the donors is a regular blood donor, and the others are the students of medicine. And you can see that this is very nice, but also controversial. Because, for example, as we did the first procedure, it was very difficult to describe to the patient. Okay, so the donor will provide you the microbes. So you suffer from the disease and you will be offered the stool from a donor. So this is very shocking for the patient. So you have to describe it really very properly to the patient. And the screening is really very strict. There are strict inclusion criteria. So the donor has to be healthy, no restrictive diets, no antibiotic treatment at all, or at least in the last 6 months. So this is very important to mention. So there is some international consensus. There was some international consensus conference on stool banking. So there are some recommendations. We have to be very particular concerning the multi-drug resistant bacteria. So this is very important issue. And of course that we have to be very careful because hypothetically we can transmit from the donor to the patient some disease that has not been described yet, or it can be non-infectious disease, like, for example, metabolic syndrome, like depression, this depressive disorder, and so on. So we have to be very careful. That is really what I wanted to mention. So I have around 3 minutes before the discussion, I hope. So what to say, like summary. So there is very nice concept that I really like. As I have mentioned at the beginning, I had the lecture for medical students before this lecture. So I always put a stress on the fact that if we take care of the patient, we also take care of the microbiota. So if we just administer some drug to the patient or the diet, we have to know that we also offer it to the microbiota, that we influence our microbiota. Our microbiota, it's a unique organ, unique and integrating organ. It's thought that gut microbiota is integrating part of a human body microbiota. Our goal is to protect our microbiota, to try our best to fight dysbiosis. I think that dysbiosis already is a diagnosis. It can be an acute or a chronic microbiota failure. Hippocrates already said, all disease begin in the gut. We now use very sophisticated methods to describe what already Hippocrates said. Fecal microbiota transplantation, or a human probiotic infusion, or a fecal microbiota therapy, or a stool transplant, how it is described, the same term, is a gut microbiota modulation strategy, and that really represents a novel challenge. I would like to introduce, and I'm very happy that we have a novel society. It's a Czech microbiome society that tries to gather the specialists and also patients and anyone who is interested in the field of microbiome in health and in disease. And we also took part in a World Microbiome Day. That was a very important day. We, of course, have to stress this every day, that there is our microbiota that we have to take care of. So coronavirus or COVID, this can also mean this. So this is how to improve our gut microbiota and to fight dysbiosis, to defeat coronavirus. So C means cool and calm, just to harmonize our microbiota, gut-brain axis. To stay calm, it's keep calm. This is very important, that I got to know in the morning when I got to know that some of the personnel is COVID positive. Optimal, it means just to offer to our gut microbes what they wish, the fibers and very diverse food to restore and maintain the diversity microbiota. Diversity matters was said in the course of the World Microbiome Day. Vivid, it means if not quarantined and if not COVID-19 ill, just go jogging, walking, and so on. So the movement, the exercise is important for the patients and for all of us. Interested in our neighbors, interested in the novel discoveries. So thanks again to that extremely interesting conference, and D, it's donated. So just to share our opinions, share our discoveries. And I think that this is our plan. This is my advice, how we can fight and defeat this dangerous pandemic infection. So this is our hospital. Again, in the course of a night service, night shift, this is what I saw out of my window in my apartment in the southern part of Prague. This is another drawing from my sister. So we just can ask whether fecal microbiota transplantation can be considered or other microbiota modulation strategy can be considered like a panacea. And thank you very much for your very kind attention. And I hope that maybe in the future I will have the occasion to meet you in person, to meet you and of course your microbiota. So I wish all the best to all of you. Take care and thanks a lot for the opportunity. Thank you very much.
Thank you. So again, we can virtually clap. Let me actually try and stop your sharing. And yeah, so it's time for questions. So if you have a question, please use the participant function. Sonia has a not a function but a question. So please go ahead.
Okay, thank you for an amazing presentation. I have maybe naive or stupid question, but do you think or do you have any evidence that the transplantation of this microbiota can be used as a tool for delivery of, for example, some therapeutic agent, for example, to cure the colorectal carcinoma?
I think this is very interesting question. Thank you for that, because I just think that the microbiota, fecal microbiota transplantation will be used like a co-treatment, treating some tumors like a melanoma in some stages. So you will just try to help the microbiota at the same time. Concerning your question, some microbes, like for example, Bacillus cereus, could be used like a factory to produce some substances, not only bacteriocins, to fight diseases in general, not only infectious diseases, but also, for example, some oncologic conditions. So I think, yes, I think it's the future. It's really very perspective. It will also have some diagnostic meaning. Analyzing the microbiota, not only the microbiome, the content, but the metabolome, maybe we'll have quite powerful tool to predict who is at risk of developing some oncologic disease or maybe some metabolic condition as well. So I think this is really very interesting field, and this is why I'm very happy that we can share our opinions and that we can really try to translate the discoveries from research to the clinical practice. Because as you can see, I'm a clinician, so this is important for me anytime. So for me, of course, I'm really very eager to know as much as I can about the novel discoveries in the research in general, and also even in the philosophy, because you know, there are some ethic problems choosing, for example, donors. Most of our patients at the internal department, they are very old patients. They don't have a relative that could be a donor. So this all is very complicated. So thank you very much for your question.
Yeah, it sounds very promising, and thank you for the answer.
So there is a nice line of questions. So Barbara was first. Go ahead, please.
Okay. Sorry, I always. Oh, thank you. Mine is also a naive question. You were telling more, I mean, that microbiota is unique for each individual. So I was wondering whether you do also some qualitative observational investigation on the individuals that you transplant and see whether they have different outcomes. Because I can imagine that if you take microbiota from healthy people and you give them to patients, maybe each of them might react in a different way. It's just a curiosity.
Yeah. So thank you very much. I don't know whether Jakub from the team is also in this conference taking part. So maybe he also could answer, because they are doing the microbiome analyses. So first step was to compare the microbiota, or better to say microbiome in healthy donors that were first 40, 45 or 50 in that first choice, and compare it with people suffering from irritable bowel syndrome, and to compare it, the diversity particularly, and afterwards to choose the appropriate donor. So you are right. We should take into account some other factors, like what the donor, what are the eating manners of the donor, whether the donor is doing some sport activities, what was the delivery mode. So this all is very important. And I really mentioned that it is unique. So we think that our design is very interesting due to the mixed microbiota than we use in the course of a clinical trial. It was said that the diversity matters. So this is what I see in my patients. There is the lack of diversity that I can just observe indirectly, because before the FMTs, normally we don't do the microbiome testing. And so we just choose the donor, but it's not due to the microbiome profile. So this will be maybe the future, as well as the metabolome, because at the moment it's very difficult to just choose some metabolome parameters that would be used, or a few parameters that would be used to match or to choose the appropriate donor. So of course you are right, it's individual, so it's a unique microbiome, but in that patients, they typically have severe gut microbiota alterations. So it's very probable that I will be successful administering a very broad spectrum, very high diversity of the microbes. So this is what we wish and what we plan to achieve using a mixed microbiota from more than a unique donor.
Thank you.
I think it's only fair to let Jakub, since I assume that's the colleague you have in mind. So please go ahead.
Yeah. Hi. First, Jiří, thanks to amazing presentation of not only your work but ours as well. But I'm a little bit confused. What was the question actually? But I'm happy to answer.
Actually, the question was how to choose how we choose the appropriate donors. I understood.
Okay, I see. Okay, I see. So
also, what are the? I mean, if there is a heterogeneity of effects in the patients, if you also study that in a qualitative way, in some way. Also, if you learn something about the microbiota doing this, I mean.
I see. Thanks for the question. Well, so the main criterion for choosing the donors was the beta diversity. So it means how different were the donors from the recipients or the real ill subjects with IBS. So that was the main criterion. So we just plotted the PCOA curve and we just chose those who were the farthest from the patients. So these are our donors.
Okay, I can join maybe that we just try to find how come that there are the differences. So we had a look many data in the analysis of the patient concerning the drugs, for example, protein pump inhibitors,
Sure.
or whether the patients are traveling abroad on a regular basis. What is the hygiene standard? Because it's very important to mention the microbes we meet every day, and of course the fiber consumption. And this is what we plan to do in the course of the clinical trial, to just compare the microbiome changes and just to correlate it maybe to some lifestyle changes, medication, conmeds, and so on. So this is really a very, very, very big task. So thank you, Jakub. Thank you.
So we
You're
started
welcome.
a little. Yeah, thanks. We started a little bit late, so we can go a little bit over time. And there are 2 questions. So Mary, please go ahead.
I have 2 brief questions, actually. First, I would like to know whether these patients need to get some conditioning before getting the transplant in order to get engraftment of the microbiome. And the second question is there anything known about how is the engraftment of the microbiome? Does it all the populations you have over there engraft into a donor, or some of them will be able to stay and some others will not? Is there something known there? Because I think that's very important to know what the outcome might be of the transplantation.
Thank you very much. Excellent questions. So there will be a bowel preparation, like quite very similar to the colonoscopy procedure. So this is the answer. And concerning the retention enema, you know, it's complicated because there is afterwards the positioning of the patient as the microbiota would be there in the gut, in the contact with the gut as long as we can. So this is complicated in the course of the clinical trial. But the engraftment, we don't know. We just try to guess how this would be in IBS patients. We know that the engraftment is very good in a patient suffering from recurrent Clostridium difficile infection, but we don't know how is that in patients suffering from irritable bowel syndrome.
Okay, and last question, Jonathan, please go ahead.
Yes. Oh, thank you. So I'll try to be quick, although maybe kind of a big question, but it's just, I mean, I've seen it written about, I guess, in terms or in microbiome research that a healthy microbiome is often what you have when you're healthy, with kind of the implication that we still don't really know enough about what exactly it is that constitutes a healthy microbiome. And I wonder, I guess, in your opinion, in this sense, do you think we know enough even about something seemingly as important as diversity to be able to say what constitutes a healthy microbiome?
Okay, thank you. That's a very nice question. So this is very difficult to say because we are all focused on the microbiome analyses. And as I have already mentioned, the metabolome is very important. So the capacity, the functional capacity of the microbiota. So for example, my bifidobacteria, their function is completely different or maybe
I think we lost you, or is it just me?
I can't hear him either.
Yeah,
We lost him.
yeah. Sorry, we no longer hear you.
Being silenced.
Yeah, sorry, it doesn't work.
It doesn't seem
I
to
think
hear.
somehow he left the meeting. Maybe by accident.
Yeah, so it's sorry, Jiří. Let me just try to check. Can you hear me? Can you not? If you can hear me, Jiří? Can you not? Because we lost. You got disconnected. The smartphone was disconnected, so we couldn't hear your like the last 30 seconds. So okay. I guess I mean, I hope if you can, of course, then please join us tomorrow. And for the Gather application, it's perfect to, you know, to answer some further questions. Like I have a question, but unfortunately we are out of time. So let's thank you virtually again with this sort of nice clap. Thank you for your talk, and it's time to move on now.